Life sure gets busy, doesn't it? Well, we understand. With all the certifications you have, finding the right kind of continuing education that fits your schedule can be a real challenge. That's where the FlightBridgeED Podcast subscription comes in. For less than $5 a month, the FlightBridgeED Podcast subscription gives you top-notch accredited CE while you listen. Visit FlightBridgeED.com for more information or to sign up today. The FlightBridgeED Podcast subscription. Another way we're being your partner in discovery.
The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. Today's podcast is going to be a debate. Recently, my good friend and colleague, Tyler Christofoli from the FOAMfrat podcast, put out a blog, and that blog alarmed me a little bit. The blog is Levophed Assisted Transfusion. Now, when I first read this, I thought it was a good write-up. I thought his thought process as far as the physiology and pathophysiology of our patients was sound. Where I got a little uncomfortable was the aspect of advocating for early vasopressor support in massive hemorrhage during that initial resuscitation phase. Now, this is a hot topic, and this is something that I have thought about and had many discussions over the years with colleagues, peers, medical directors. What about those patients that we see in multi-systems trauma with associated traumatic brain injury? Should we not protect the brain? And I think that was his thought process in this write-up, in this blog. We obviously recently had the EPIC trial that really put a focus on traumatic brain injury and all aspects of hypoxia, hypotension, and now hyperventilation. And I'm going to hit on that in a little bit. I think the big problem here is that there is no clear clinical evidence that supports early vasopressor administration in that early resuscitation phase in trauma, regardless if this is with traumatic brain injury or not. So I'm going to kind of take a focused look and look at the literature. And Tyler and I have had conversations since this article has been released, and we've talked about this via phone, and I think it's good for both of us to have this dialogue back and forth. So we're going to kind of do this debate and look at this from different perspectives. I think he definitely has a certain type of patient in mind, and I'm going to leave that to him to put out. And I actually have to somewhat agree with him in that thought process. However, I think we have a responsibility as clinicians, as paramedics or nurses, to always go back to the evidence. And I think it's very difficult at times to kind of step outside that box. So let's dive in. Throughout this discussion, I'm going to go over 3 different papers. This is not going to be a long podcast, but I want to just highlight the different aspects and thought processes. I'm definitely going to take a look at the rationale for vasopressor use, right? I think a lot of it is very logical. The first paper I'm going to talk about is what's called Early Vasopressor Use Following Traumatic Brain Injury, a systematic review. This is actually, again, a review, and they looked at a total of 8,001 citations. They retrieved 18 full text that included 6 studies, 1 randomized, 5 observational, including 2 published exclusively in abstract form. So I'm going to highlight different parts. Again, I will post every one of these articles in the show notes. You can find that on the FlightBridgeED website under podcasts, under this title in the show notes, and you can download those and take a look for yourself. Number 2, early use of vasopressors after injury. Caution before constriction. And number 3, vasopressors, do they have any role in hemorrhage or hemorrhagic shock? As I said, I think this article is very well written, and all kudos to Tyler. I think Tyler is a brilliant clinician, and he is far ahead of the game. With that being said, I think that there are areas of this that I agree with, and there's areas that I disagree with, and I just want to put this out. So I'm going to read some areas of his article, and again, I will put a link to this blog article in the show notes, so you can go to the FOAMfrat website and read this for yourself. So one of the first subheadings that I want to address: change the size or compliance of the container. This is what he says, in quote, "This is an area that is an interest of me. It takes some time for the volume to increase preload enough to increase stroke volume. As that ticking begins to get louder, many will result to shitloads of saline or push dose pressors to elevate the blood pressure while waiting for blood products to increase hydrostatic pressure enough to elevate our MAP. I think push dose pressors, specifically epi, is the wrong move because of the reasons mentioned in my Manipulating the Pump Dynamics article. It is rarely the right move, so what do I do?" When you look at this, I think when we are resuscitating our patients, and if I could just kind of chime in on that area right there, I do think push dose pressors are kind of putting a Band-Aid on a massive hemorrhage, right? You got a limb that's cut off and you put a Band-Aid on it. And I definitely think that we have become enamored in going to that push dose pressor. Now, I definitely think there are times where that is warranted. I definitely think there's better push dose pressors out there than epi. I definitely think vasopressin is the go-to, especially in trauma. And I've addressed that on other podcasts. And I know that is being studied currently by Air Methods. So I would have to agree that just putting a push dose pressor in place, dumping tons and tons of normal saline, is the wrong approach. We definitely need to guard against a low MAP in that trauma patient that has an associated TBI. And I think that's where we really have to focus our attention. Definitely literature out there that shows that a MAP of 60 in that trauma patient penetrating or blunt force trauma without traumatic brain injury is warranted. There are now guidelines, ATAC guidelines, that are actually saying a MAP of 50. I did a podcast with Dr. Morris out of Grady Memorial in Atlanta, where we talked about REBOA, and we talked about MAPs of 50 in those penetrating trauma patients, right? We have healthy young males primarily in that age demographic, and they can handle a MAP as low as 50. It's when we have that associated TBI, which is a massive, massive amount of our trauma patients. So I think that is where we really have to focus our attention on. And I think that's where we get a little bit uncomfortable, is we know that a cerebral perfusion pressure of 70 is the goal. If we estimate a ICP of 20 in a TBI patient, we know a normal ICP is between 0 and 15. You take that MAP minus the ICP to equal a cerebral perfusion pressure of 70, we would need a MAP at 90. And sometimes that is far from what you have in that severe hemorrhaging patient. So what do we do in that situation? What is the rationale? And what is Tyler's thought process? Well, this is what he says. I believe a temporary Levophed Assisted Transfusion is entirely reasonable in this situation while waiting for blood products to catch up with preload requirements. He goes on and says, Levophed begins its action by increasing unstressed volume to stressed volume. This is like giving a fluid bolus, but without the negative sequelae of crystalloids. Squeezing the venous capacitance, this system will directly increase preload and expedite cerebral perfusion. So as I said, let's look at the rationale. Let's look at this from both sides. If we look at the first article, early vasopressor use following traumatic injury in a systematic review. Again, this was the one that looked at that systematic review of over 8,001 citations. And so when we look at that and we take certain aspects of that paper, what did this paper highlight as a rationale? Here's what it says. In a prospective observational study conducted in 102 severely injured patients, so again, that's a very small sample size, it was observed that infusion of crystalloid solution during the first 24 hours associated with increased pulmonary dysfunction. Although no direct relationship between fluid loading and pulmonary dysfunction could be established, a new thought process was evoked for the indication of the use of vasopressors during early stages of resuscitation. Moreover, restrictive fluid therapy and vasopressor therapy to optimize MAP and cerebral perfusion pressure may also be beneficial in that head trauma patient. Volume-sparing effects of vasopressors may lead to decreased cerebral edema and maintenance of adequate blood pressure in polytrauma patients with head injury, in whom even a single episode of low blood pressure may prove detrimental and worsen the outcome. I guess I have nothing really to disagree with that statement. I mean, I think that is very sound in its thinking. I definitely would agree that seems like a very cut and dry type of a thought process. And so based on that rationale, I would have to agree with what Tyler is saying. The problem is that we definitely have a multitude of things in this paragraph to kind of talk about. I think when you have patients that are being administered crystalloids, normal saline LR in trauma, we know that definitely worsens outcomes. So that is definitely not the thought process we need to go down. We definitely know that blood replacement therapy, we know the proper trial invoked a 1:1:1 ratio of blood products, and we know that actually improved outcomes in that initial stage at 24 hours. A MAP of 60 in that polytrauma patient without traumatic brain injury is warranted, as I said before, but it gets a little bit convoluted when we add the whole cerebral perfusion pressure and the need in that head trauma patient. So I can definitely see, and I will have to say, and I've talked to Tyler about this, that 10 years ago, that was my thought process. And I say 10 years ago because I've had this discussion multiple times with Dan Davis. I've had this discussion many times with Alan Wolf about this exact therapy. So let's continue. Do vasopressors have a role in hemorrhagic shock? The use of vasopressors is not recommended according to ATLS. So I think that's important to note. Now, with that being said, I know there are a lot of different thought processes on ATLS, and that's just one course. That is one thought process. We know the role of vasopressors, though, remains controversial. And I think we could all agree that when you look at the timing of infusion, the type of infusion, the dose, in this hemorrhagic shock patient, it becomes very unclear in when and what to do. With that being said, I think when you look at vasopressors in trauma, the two vasopressors that are highlighted in any study has been only Levophed, norepinephrine, and vasopressin. And obviously, I just did the review of the AVERT trial. Again, effect of low-dose supplemental administration of arginine vasopressin on need for blood product transfusions in patients with trauma and hemorrhagic shock. I just released that a few days ago if you haven't listened to it. And we saw that there was a pretty massive reduction, 3 units of packed red blood cells, 4 units of FFP when vasopressin was administered after, but here's the thing. Remember, it was after 6 units of total blood products had been administered. So it wasn't vasopressor support in that initial resuscitation phase. They still filled the tank with blood. They still got that volume on board. They still took these patients to surgery, right? So they did get a bolus dose of vasopressin in that initial resuscitation. Again, this was within 12 hours of injury. So anybody that came into that level 1 trauma center within 12 hours of injury was either given the placebo or the treatment arm, and that was a 4-unit bolus dose if they had received 6 units of total blood products, and they didn't have any exclusion criteria. And again, go back to that podcast. Again, the study is in the show notes. But when you look at that, vasopressin actually showed a benefit. But again, the drip was started. The patient was taken to the OR, and that was that post-resuscitation phase. And so I think that's a lot different. And I think that we have to be very, very aware of that. Here's the thing. The problem that I go back to is we don't want to squeeze our vessels down. If they're not full of volume, if you have a massive hemorrhage patient and we're depleted, our H&H is dropping, we're becoming hypemically hypoxic, and we squeeze them down. Again, I understand the thought process of attempting to increase that MAP, which is going to ultimately increase cerebral perfusion pressure. But we have to understand the intense vasoconstriction may even result in end organ ischemia. That end organ ischemia is going to cause an impairment of oxygen delivery that is going to lead to anaerobic respiration and ultimately metabolic acidosis. We already know that these patients in massive hemorrhage, even in being administered packed red blood cells, even going the 1-to-1-to-1, we know packed red blood cells have citrate. We know the whole aspect of citrate. I've talked about this on other podcasts. We know that leads to inflammatory response. These patients can go into DIC. And so I think that we have to come back to, it may give us that initial impression, hey, we have increased that mean arterial pressure, we've increased that cerebral perfusion pressure, but what are we doing long term? That vasoconstriction is going to lead to that end organ ischemia, reperfusion injuries, etc. And that's where I come back to and say, could we wait an extra 5 minutes? If we go back to his initial thought of augmenting that infusion of blood with early Levophed administration, are we jumping the gun? What is our subset of patients that we're primarily treating? We know that really, we'll say 15 to 40-year-old males, right? And I'm sure that there's kind of a more narrow range. Those are the most common multi-systems trauma patients. So when you're looking at those patients, and I will admit, I've talked to Tyler about this, we've discussed this, and we agree that subset of patient, maybe his thought process isn't really warranted. But again, he is going to lay out an argument on maybe a different type of patient. And this is where he jumps into the whole bathtub analogy. I quote, "Sometimes we don't have time to wait for the bathtub to fill up, and we need to change the compliance of the container by jumping in. I believe that Levophed has the utility to be the fat kid in the swimming pool when seconds are critical to brain perfusion." So that's kind of like my bulldog Gusser jumping into the bathtub, right? And if you know me, I always joke about Gusser and how big he is. But are we jumping the gun? Could we get that blood on board in enough time? Are there other things that we can do to prevent a hypotensive drop that is sustained and causes a low cerebral perfusion pressure? I think it's also important to understand that we often focus a cerebral perfusion pressure on our TBI patients, adults specifically, at a number of 70, but we can manage, I think, just fine between 60 and 70. I think 70 is that perfect golden number. I think that you're probably pretty safe in most cases between 60 and 70. Definitely below 60, I think you're getting into an ischemic type of a phase that we want to stay out of. And we know pediatrics can handle a lower number, and 60 is absolutely appropriate for them. So here's my response. Do they have a role in that hemorrhagic shock? I think when you look at norepinephrine, it's been found to increase that myocardial performance. It increases cardiac index, increases coronary perfusion. It also improves end organ perfusion in trauma patients. Norepinephrine increases cerebral perfusion pressure, although it causes no improvement in cerebral oxygenation. which improves only after transfusion in hemorrhagic shock. So that is the key. Norepinephrine, I would agree, is a phenomenal choice. My go-to choice, and the go-to choice for most out there. I think it has definitely made a comeback over the years, where 20 years ago it was Levophed, leave him dead. And now it is the go-to vasopressor in almost every type of vasogenic or distributive type of shock. And it does increase cerebral perfusion pressure. It does improve cardiac index and stroke volume, myocardial performance, etc. But if we're not improving that cerebral oxygenation, are we clamping down? Are we causing any secondary ischemia? I don't know. It's kind of like, you got a pressure on the monitor, and I go back to, the intense vasoconstriction and the secondary result of end organ ischemia. When you look at the EPIC study that he talks about in this paper or this blog, I think the area that I struggled with was the hypotension side. And if you read the EPIC study, and I will put this in the show notes, this study was focused on looking at the hypotension, the hypoxia, and the hyperventilation. The EPIC study was the evaluation of the impact of implementing the Emergency Medical Services Traumatic Brain Injury Guidelines in Arizona, the Excellence in Pre-Hospital Injury Care Study Methodology, and that was EPIC. The key, obviously, when you look at hypotension and hypoxia, we've focused on this for years. We know that one episode of hypotension, one episode of hypoxia, each of those carry a big weight, up to 50% mortality with each one of those. So we go into these patients, we focus our care on airway management, on preventing that hypoxia. But obviously, there are many times that we get on scene, you land on a scene flight, patient has already become hemodynamically unstable. They're already hypoxic because they're agonal, or they have a traumatic brain injury to the point where they're not ventilating appropriately. So I think the whole hypotension hypoxia thing has been a focus for years, and we really have taught, hey, really look at that map. Again, that was his focus on this blog. I think it's perfect and a perfect thought process. And hypoxia. Once we take care of this patient, or we start our care with this patient, the key is not to allow them to progress to a hypotensive or hypoxic episode. And the last thing that they really focused on was a hyperventilation thought process, that we know that in the past we focused our care on keeping that end-tidal CO2 between 30 and 35. I think many times we go a little bit overboard and we end up with an end-tidal in the 20s. But we have learned that maybe that's not the best option. Maybe that's not the best thing. And so hyperventilation is now a third H in that whole TBI algorithm. We want to prevent hyperventilation. We don't want to cause a patient to become hypocapnic. We know a low CO2 level causes global vasoconstriction. That's going to cause ischemic changes. So I think we need to be cognizant of that. I think keeping an end-tidal between 35 and 40 is probably a great thought process. But when we look at this study and we come back to kind of the point, volume replacement in this study was fluid. That's it. No vasopressors. So I think it is unwarranted to highlight this study as a reason. And again, I'm not bashing the thought. I think he challenges me, and I think he's an amazing friend, but I think that's jumping the gun. And I think sometimes we agree to disagree on things. This is what I'm going to end with. Although vasopressors may have beneficial effects in resuscitation, in hemorrhagic shock, one should not undermine the fact that balanced fluid resuscitation, balanced blood product administration, it remains the first priority in our management. Vasopressor administration in the absence of adequate volume, in fact, actually worsens outcomes. It actually increases mortality. We know that blood product administration remains the mainstay. We know that that is the mainstay in that initial resuscitation phase in hemorrhagic shock. I think vasopressors have a role in resuscitation when you have that vasoplegic shock, right? So your patient is not responding to any therapies. And blood pressure cannot be maintained by fluids and blood products alone. But I think that we have to make sure that we are filling the tank. And I just don't know if it is warranted in the pre-hospital setting. I don't think we carry enough volume on our ambulances or our helicopters. And I think that that needs to be something that happens later in the whole resuscitation phase. I definitely think that vasopressin has been shown, but as I highlighted in the podcast on vasopressin and the AVERT trial, I don't know if that protocol is even warranted for the pre-hospital setting, because we are probably not going to have a situation or setting unless this is a transfer type of a call, and they already have 6 units of total blood products. It's within the 12 hours. Then I absolutely feel like vasopressin, a bolus of 4 units, and starting that drip would be warranted. But even though I think that that study is amazing, I don't know if it's right for the pre-hospital setting on a scene flight or 911 call in that initial hemorrhage, even in the associated traumatic brain injury. So that is my synopsis. Again, I will put all these articles in the show notes. I look forward to Tyler's response. And thank you so much for all the support.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.